A'udhu billahi minash shaitanir rajeem. Bismillahir rahmanir rahim. Assalamu alaikum, ladies and gentlemen. Greetings from Karachi. I would have loved to be in Lahore at this time to present my findings and to participate in this wonderful conference. But because of the present circumstances, we are working from a distance. We are working remotely. So to begin with, I thank Allah subhanahu wa ta'ala and I praise Allah subhanahu wa ta'ala. And then I thank Dr. Tafazzul and his team for arranging this extremely beneficial conference and also inviting me to participate in it. Thank you very much. Okay, so we are going to talk about osteoporosis. As we all know, it is a very, very common disease, and as yet, we have only reached the tip of the iceberg. The problem is immense, absolutely immense. And what we are tackling about osteoporosis is only the tip of the iceberg. So you all must be familiar with this picture, and it shows the journey of a woman through her life. So looking at this, I really feel compelled to recite an ayat from the Quran in which Allah subhanahu wa ta'ala says, لَقَدْ خَلَقْنَا الْإِنسَانَ فِي أَحْسَنِ التَّقْوِيمِ, that we created mankind in the best of balance. ثُمَّ رَدَدْنَاهُمْ فِي الْأَسْفَلِ السَّافِلِينَ, and then we reverted him to the lowest of the low. Allah creates human beings in the best of the balance, and then as time goes on, changes take place, and changes take place, and changes take place until they are reverted to the lowest of the low. So this is the story of osteoporosis, actually. And according to WHO, what is osteoporosis? It is a disease characterized by low bone mass and microarchitectural deterioration of bone tissue, leading to enhanced bone fragility and a consequent increase in fracture risk. So this is the normal bone, tightly woven normal bone, and this is an osteoporotic bone. And you can see that huge sieves have formed, and the bone itself has become a huge sieve. छलनी की तरह से हो जाती है बिल्कुल हड्डियां. Okay, now primarily today we are going to talk about postmenopausal osteoporosis. But since I'm talking on this topic, I would like to give you a brief overview of the entire disease. So we have basically two types of osteoporosis: primary osteoporosis and secondary osteoporosis. In primary osteoporosis, basically we have the postmenopausal osteoporosis and senile osteoporosis. And in secondary osteoporosis, osteoporosis is induced because of certain diseases and because of certain drugs. So as you can see, this is type 1 osteoporosis, postmenopausal, and this is senile osteoporosis, age-related. So it can occur in males or females, both. Okay, now some of the causes of secondary osteoporosis, such as prolonged bed rest, prolonged immobility because of plaster casts, again, prolonged immobility because of paraparesis, paraplegia, quadriplegia, etc., and also weightlessness in space. Okay, now certain dietary deficiencies cause osteoporosis. Certain drugs cause osteoporosis. Then we have certain idiopathic causes. And of course, we have certain genetic disorders. Certain chronic illnesses such as rheumatoid arthritis, such as cirrhosis, sarcoid, such as kidney diseases, also lead to osteoporosis, and so do certain neoplasms lead to osteoporosis. And of course, not to leave behind the endocrine abnormalities, abnormalities related to the pituitary, to the adrenal cortex, the ovary, the testes, the parathyroids, and the thyroid gland. Abnormalities pertaining to all of these also cause secondary osteoporosis. Now, a few words about the prevalence. And as I just said, we are going to talk about mainly post-menopausal osteoporosis. So, this is primarily a disease of post-menopausal women. However, 20% of osteoporotic patients happen to be men. And a woman's risk of hip fracture is equal to her combined risk of developing breast, uterine, and ovarian cancer. So one can imagine the magnitude of this problem. And a total of 75 million persons are affected in Europe, USA, and Japan, and an estimated 200 million women suffer from this disease worldwide. So that is why I said we have only touched the tip of the iceberg. And again, the highest incidence has been seen in whites and in Asian women. Now, this seems a little odd because of the difference in geographical conditions and, Europe versus the Asian countries. But perhaps there is some kind of a genetic sharing that the white women as well as Asian women, they have a highest incidence of osteoporosis, because otherwise there are lots of differences relating to geographics, relating to their lifestyles, relating to the economic status, etc., etc. So more than 2 million fractures per year are seen in men and women over the age of 50 years. Out of these, 300,000 are hip fractures, 550,000 are vertebral fractures, and 400,000 are wrist fractures. And you can imagine the huge economic impact this disease has. You can see that the annual combined medical cost of treating 2.3 million osteoporotic fractures in Europe and US is $27 billion. And an estimated worldwide cases of osteoporotic fractures are 5.2 million. So we can imagine the cost of treatment. The cost is simply immense. And another very important factor is that we are having graying of the planet. Now, what is graying of the planet? That the elderly population is rising. Why? Because now there is timely treatment of various diseases. There's timely treatment of infections. There's a lot of prophylactic medicine involved, prophylactic health care going on. Hence, the longevity has increased. And because the longevity has increased, there are a lot of elderly people, and the planet is now graying. And so we can imagine the increase in the number of fractures. So this is an estimated economic impact of $25.3 billion by the year 2025 and $50 billion by the year 2040. And we have a lot of loss of human resource. 20% of patients with a hip fracture die within the first month of injury, and 20% have severely impaired mobility at the end of the first year. 50% experience long-term pain and disability. And also, men with hip fractures have a higher mortality than women. Only 58% are alive after 1 year, as compared to 77% of women. And also, a very important fact, following a hip fracture, chances of a second fracture tend to rise many folds in the following year. So we know that this is a very, very neglected disease. 2/3 of all vertebral fractures are asymptomatic. It is called the silent killer because it is asymptomatic, especially the vertebral fractures. They are simply asymptomatic. There is no symptom. There may be some cases of back pain, otherwise there are no symptoms. And then 85% of women are not even aware that they are at risk of developing osteoporosis. And also less than 20% of women with osteoporosis are being treated. And mind you, these are the figures that we've obtained from the West. I'm sure our figures over here must be very, very low. Okay, so now a few words about the risk factors in females. The major risk factors over here are that there is a history of osteoporotic fracture as an adult, history of a low trauma fracture in a first degree relative, having a small or thin frame, and then smoking, alcohol intake, all of these are major risk factors, and also intake of oral corticosteroid therapy for more than 3 months. Additional factors are Caucasian or Asian breed, advancing age, a diet low in calcium, decreased physical activity, estrogen deficiency at an early age, that is less than 45 years, impaired vision, and dementia. Okay, now a few words about risk factors in males. And these are, to begin with, decreased testosterone levels, glucocorticoid use, that is more than 7.5 milligrams for more than 3 months. Then again, alcohol and smoking and certain other diseases like hyperparathyroidism, intestinal disease, malignancy, mobilization, etc. So now we know that the pathophysiology of bone is, in fact, we know that bone is a living tissue, and it is in a state of constant turnover. There is increased rate of formation in younger ages and increased rate of resorption in later ages. And this is, in fact, in women, the effect of estrogens. So this is normal bone resorption and normal bone formation. So whatever bone gets resorbed is new bone forms, so there is no resorption. Whereas in osteoporosis, if this is bone resorption, this is bone formation. It is not complete. Bone formation is not complete. So what is the result? That lacunae get formed. Again, the osteoclasts, lining cells, the bone, leading to osteoclasts. When they start resorption of bone, this is what happens. This is what happens. And then because the bone becomes fragile, then breaks appear in the bone, and finally, there are microfractures in the entire bone. Now compare this with this. Again, bone remodeling. And then this is the natural history of osteoporosis. This line represents females and this line represents males. We see that the bone mass, this is the bone mass, and this is the age. We see that the bone mass in men and women both keeps on rising. In men, it rises far more greater than women, and it tends to plateau at the age of about 30. And in women also, it rises, but much slowly, and it plateaus at about the age of 30. And then after 30, the bone mass starts to decline. It declines very little in men, and it declines almost sharply in women. Now, this is the period from here till here where there is no investment in the bone bank. In fact, whatever comes in goes out in terms of pregnancies and lactation, etc. And this is the time of menopause. We could say this is the perimenopausal age, and then the menopausal age in which the bone mass declines sharply. So this is what happens to the vertebral column. Kyphosis takes place. Okay. Now, and what happens to the vertebral column? Because of these fractures which are taking place, the height of women starts to decrease. You must have seen that you must be having grandmothers. Those of you whose grandmothers are alive, you must have seen that their height keeps on decreasing. And why does it decrease? Because this process is going on. Kyphosis develops and the height keeps on decreasing, resulting in fractures of the vertebrae, the hip, and the wrist. Okay, now these are some of the fractures. This is a fracture of the wrist, another fracture of the wrist, another fracture, radiographic representation of wrist fracture, again a wrist fracture, fracture of the vertebrae, fracture of the neck of the femur. Okay, now this graph shows us the incidence rates for vertebral, wrist, and hip fractures in women after the age of 50. And this is the vertebral fracture, this is the wrist fracture, and this is the hip fracture. So we can see that we have maximum number of vertebral fractures followed by hip fractures. Okay, now this is very interesting. What kind of fractures do we get? We get basically three kinds of fractures of the spine in osteoporosis. This is wedge deformity. The vertebrae become like wedge, progresses. See what the vertebra has become in grade 3, severely deformed. And then there can be a biconcave deformity, grade 1, grade 2, and grade 3. Progression of osteoporosis. And then we can have crush deformity, grade 1, grade 2, and grade 3. So this is what is happening in the spine. And as a result of this, what is happening? The osteoporotic spine develops kyphosis because the vertebrae are developing fractures. Therefore, the spine gets kyphotic like this, and eventually like this. So what is happening? The height keeps on reducing, 1. And now because of kyphosis, this is the normal erect posture. And at the age of 55 years, at the age of 65 years, because of this osteoporosis and kyphosis developing, there is cramping in the thorax and also the abdomen. There is cramping, there is congestion of organs. They all get cramped up together, right? And over here, this is the extreme form. So what happens? The vital capacity decreases, pulmonary capacity decreases, and the viscera all get cramped up in the abdomen. A pot belly develops, and this results in what symptoms? Back pain, loss of height, kyphosis, fractures following minor trauma, repeated fractures, and others. What other features develop? Pot belly, decreased pulmonary capacity, and reflux esophagitis. Now, if you go back to this figure, what is happening? Because of this bending of the spine, the space in the thorax is decreasing, space in the abdomen is decreasing, and the pot belly develops. There is decreased pulmonary capacity, right? And because of cramping, because of congestion of all the viscera over here, what is happening? The patients tend to develop various other problems like reflux esophagitis. So now, how do we diagnose actually? At times, the diagnosis is very tricky because as such, there are no symptoms. Now, if a person presents with these features, osteoporosis should come to our mind. An elderly comes with these features, osteoporosis must come to our mind. Decreasing height and shortness of breath, esophagitis, gastritis, etc., etc. Okay, now according to WHO, what should the diagnosis depends on, number one, risk factor evaluation, and number two, measurement of the bone mineral density. And if it is less than 2.5, below the mean peak value, this is osteoporosis. So who should be tested? All women 65 years and older, regardless of risk factors. They must have a bone mineral density test done. And then younger women who are postmenopausal with one or more risk factors. And then postmenopausal women who present with fractures. All of these three should be tested, that is, bone mineral density should be performed. This is the DEXA scan, the bone mineral density being done. Okay, another very useful tool is OSTA, O-S-T-A. And in this, we take weight versus age. We plot weight against the age. And this is a very helpful modality because it is simple and quick. And this tells us who is at risk. It is a screening tool actually. And then whoever is at risk can go ahead for a bone mineral density testing, and then they can be treated. So this is the graph that we use for OSTA. And this is the axis on which we plot the age. And this is the axis on which we plot the weight. And this is a low risk area. This is a slightly higher risk area. And this is highest risk. This is low risk, medium risk, high risk. So, okay, now people who fall in this area have a high risk. What recommendations do we follow for them? Measure their BMD if possible, consider pharmacological treatment, and even if BMD is not available, then consider pharmacological treatment. Women falling in the medium risk, what should be done? Their bone mineral density should be measured and pharmacological treatment should be instituted if BMD is low. And women who fall in this area, their bone mineral density is probably not necessary unless other risk factors are also present. Okay, now we come to the treatment. So, who should be treated? Okay, we need to initiate treatment to reduce the fracture risk, basically, in women with a BMD T-score of less than 0.2 with no risk factors, a BMD T-score of less than minus 1.5 with one or more risk factors, and wherever there's a history of a previous vertebral or hip fracture. So what should be the expectation for the treatment of osteoporosis? Whatever the treatment we institute, it should be effective in reducing fractures, should be rapidly acting, consistent across all the different skeletal sites, sustained in action, safe and well tolerated, and cost effective. And the options available are calcium and vitamin D, hormone replacement therapy, SERMs, bisphosphonates, calcitonin, and teriparatide, etc. So what does calcium and vitamin D do? Calcium and vitamin D are helpful in building bone mass in growing children and adolescents. It is important in correcting subclinical vitamin B deficiency in selected elderly populations and reducing fractures. Basically, calcium and vitamin D is used primarily as an adjunctive therapy with more potent osteoporotic medications. So all women over the age of 50 must receive calcium of 1200 milligrams per day and vitamin D of 400 to 800 milligrams per day. Okay, now we talk about hormone replacement therapy, which was very fashionable in the olden days. However, now there is limited conclusive prospective trial evidence to support vertebral fractures, fracture reduction benefit. And the HERS trial demonstrated no statistically significant reduction in hip fracture or any other fracture for a period of about 4.1 years. Now, in the olden days, this was the most widely used therapy for postmenopausal women. However, a study was conducted, which was called the WHI study, Women's Health Initiative Study, and this was done. This was done to see recent secondary prevention. Yes, we'll go back to this. The WHI study, Women's Health Initiative study, was causing physicians all over the world to relook at this therapy as an option. And what was this actually? Recent secondary prevention studies provide compelling evidence that there is no protection against further cardiovascular events for women with coronary heart disease who take hormone replacement therapy, and there may be actually real harm. So the objective of this study was to assess the major health benefits and risks of the most commonly used combined hormone preparation in the US. And this was a multi-center double-blind study. And the mean age of women was 63.3 years. And it was supposed to have a follow-up of about 5.2 years. But there were absolutely unanticipated findings as the study went on, and it was seen that women who were receiving hormone replacement therapy were having greater incidence of coronary heart disease as compared to placebo, strokes as compared to placebo, various other events as compared to placebo. So the study was stopped midway. It was stopped midway, and that gave rise to the advent of the SERMs. Now, what is SERMs? What are SERMs? SERMs are selective estrogen receptor modulators, and they have an agonistic effect on the bone and the cardiovascular system, and an antagonistic effect on the breast and the uterus. And the most popular drug used here was raloxifene. It was effective in dealing with other postmenopausal problems as well. and there was a decrease in the incidence of vertebral fractures over 3 years. However, the side effects were hot flushes and DVT. Okay, now recently there's another preparation, bezidoxifene. This is an FDA-approved therapy for osteoporosis. It is a fixed-dose combination of conjugated estrogens with a SERM. This is in this ratio. It's being used. 4.5 milligrams. Sorry, this is a misprint. 4.5 milligrams of conjugated estrogens along with a SERM of 20 milligrams. And however, as opposed to raloxifene, here there was no reduction in the risk of CA breast. And the long-term effects of this preparation again were thromboembolic events. So another class of drugs is the bisphosphonates, and in this we have alendronate, residronate, abandronate, and zoledronic acid. Now, a few words about alendronate. It is effective in reducing fracture risk at all sites, such as the spine, hip, wrist, etc., by about 50%, and it reduces incidence of spine fractures also by about 48%. And it is given orally, daily, or once weekly, or once monthly. So the daily regime is now no more practiced, and we go for the longer duration regimes. Another drug is Residronate, which reduces the incidence of spinal fractures by about 41 to 49% and non-spinal fractures by about 36% over a period of 3 years. Again, given orally once daily and once weekly. Again, this regime has been, it is no longer being followed, and we are going for the longer regimes. So if the bone was followed for about a year on this drug, there was no deterioration in the microarchitecture. And even if it was followed for about 3 years, there was no reduction, no deterioration in the microarchitecture of the bone. Okay, now we have abandronate as well. This is given 150 milligrams orally once monthly, and also an injectable preparation is used once every 3 months. So the problem with bisphosphonates was that of the route of administration, because we all know that it's supposed to be given first thing in the morning with a full glass of water, and the patient is not supposed to consume anything for about half an hour and not supposed to lie down for about half an hour. So the mode of administration is a little cumbersome, and then it has GI side effects, and then it has to be combined with vitamin D as well. And then we have this injectable preparation, which is the zoledronic acid. This is an IV infusion of about 5 milligrams every in 100 ml, given over a minimum period of 15 minutes. And the convenience is that it is given just once a year. So it is given to patients who have a poor compliance on oral therapy, as well as those who prefer the convenience of once a year treatment. The caution to be observed here is pre-infusion, the creatinine clearance must be more than 40 ml per minute. There should be good hydration. There should be prior correction of pre-existing hypocalcemia, and post-infusion, there should be adequate intake of calcium and vitamin D. And a trial of 3 years showed that the BMD increased by 6.7% in lumbar spine and by 6% in the hip. And the decrease in fracture risk was 70% at the spine, 41% at the hip, and 25% at other sites. Side effects, however, were a bit of pyrexia, some myalgias, flu-like symptoms, headaches, and arthralgias, but all of these were short-lived. And then we come to calcitonin. This is very effective. It effectively reduces risk of spinal fractures. And an additional feature that it has is that it has a marked analgesic effect, used in the form of a nasal spray and an injectable form, 200 international units of the drugs. And then we have teriparatide. This is an anabolic agent, builds new bone. Administration is daily by a subcutaneous injection. It decreases the risk of vertebral fractures and non-vertebral fragility. The indications are for the high-risk group, that is, male and females with previous osteoporotic fractures, multiple risk factors, very low BMD, and those who are unresponsive or intolerant to other therapies. So the results showed that compared to placebo, 20 milligrams of teriparatide caused the BMD in the lumbar spine, increased the BMD in the lumbar spine by about 9% and the femoral neck by about 3%. And resultant fractures showed that new vertebral fractures decreased by 11% and new non-vertebral fractures by about 3%. The adverse effects, however, were leg cramps, dizziness. The use is currently limited to just 2 years because the study was stopped early due to the production of osteogenic sarcoma in animals. Okay, now a very popular drug nowadays is Denosumab, also known as Prolia. Okay, this is a monoclonal antibody inhibiting the proliferation and maturation of the osteoclasts, thus preventing bone resorption. And hence, it reduces vertebral fractures by about 68% and hip fractures by about 40%. It is relatively well tolerated, can be given to patients with kidney disease as well. It is administered in a dose of 60 milligrams subcutaneous every 6 months, and it is given for a period of about 3 to 5 years. The indications include osteoporosis, of course, major fragility fractures, osteopenia with a high FRAX score in men and women, and in patients receiving sex hormone suppression therapy for breast and prostatic cancer. Side effects include hypercholesterolemia, eczema, dermatitis, new malignancies, etc. And it has been shown to be teratogenic in animal studies. Hence, it is given for a period of only 3 to 5 years. Okay, now another preparation, which is Romosozumab. This is an injectable monoclonal antibody which increases new bone formation and decreases bone resorption. The dose is 210 milligrams subcutaneous per month for about 12 months. This is to be given in very severe osteoporosis, and it is contraindicated in patients with cardiovascular diseases. Okay, now a few words about glucocorticoid-induced osteoporosis. This happens regardless of age and gender. Anyone who has been receiving glucocorticoids for a period of equal to or more than 3 months in a dose of more than 7.5 milligrams per day is liable to develop this kind of osteoporosis. And we see that all of these diseases in which we need to give steroids These patients can develop glucocorticoid-induced osteoporosis such as asthma, COPD, rheumatoid arthritis, lupus, inflammatory bowel disease, etc. So, a significant amount of bone loss develops within 3 to 6 months of therapy. And with continued therapy, the bone loss is also continuous. And up to 50% of patients taking above 7.5 milligrams per day of prednisolone or its equivalent may have fractures. And the treatment here is bisphosphonates along with calcium and vitamin D. Okay, now a few words about the prevention. Of course, prevention is better than cure. We must counsel all patients on risk reduction, improving their lifestyle, ensuring adequate intake of calcium and vitamin D, provide them guidelines for regular weight bearing and muscle strengthening exercises, counsel them on fall prevention, and abstain from smoking and alcohol. So, a good nutrition, good intake of calcium, multivitamins, vitamin D, sunlight, physical activity, etc., etc. So with that, I think I've come to the end of my presentation. And in the end, I would like to recite a verse from Surah Al Imran in which Allah says, "Behold, in the creation of the heavens and earth and the alterations of night and day, there are indeed signs for men of understanding." With that, I thank you for your time and attention. Jazakallah khair. Assalamu alaikum.